Hello everyone, welcome to the third episode of Revising Dentistry. Today we have Dr. Niranjan Vatkar as a special guest. He's a practicing micro-endodontist, micro-restorative dentist from Pune, Maharashtra. We have created a two-series podcast with him discussing his favorite topics, restorative and endodontics. Get ready with pen and diary and let's start learning from the dynamic, inspirational visionary Dr. Niranjan Vatkar. Welcome, Dr. Niranjan, to the podcast. How are you doing?
It's great. It's been great. And first and foremost, I would really like to appreciate the efforts that you're putting in, increasing the, I would say, educational platform in India, because this is something which is lacking.
Yeah.
And the step that you have definitely taken in introduction of this revising dentistry, that's a great initiative, and my best wishes to you.
Thank you so much. Thank you so much, Doctor. Means a lot to me.
Yeah.
Yeah. So, Doctor, I went through your website. I did a little research.
Okay.
And first thing I wanted to ask, do you really play piano?
Definitely not. The videographer who was actually shooting, he said, it would be a great thing to put into the relay. So that is the reason why I just enacted. So
But it
definitely.
has given a beautiful touch to your video.
Thank you.
Definitely, definitely. Restorative dentistry. As I know that, that's your forte. That's something that you master in. And let's get into the history of restorative dentistry. We had a very few materials back then when actually dentistry was maybe when I learned or maybe you learned at that point of time, we had very few materials in our hands.
True.
So what do you think, from where we started, what is the history?
Yeah. So if you actually go into depth of restorative dentistry, composites was definitely not the first material that actually came into the picture. So before that, there were something called as silicate cements. So those were introduced first, but of course in their initial days, it was just the first restorative, or I would say aesthetic material that was introduced for treatment of aesthetic treatments. It had its drawbacks. It was not the best material, but definitely it gives some result to the patient as compared to the conventional amalgam or maybe the glass ionomer cements which were there.
Yeah.
So that is I would say the first point from where the first step of restorative dentistry that actually started.
True.
Later on, then bonding agents were introduced to increase the bond strength of any material to the tooth. So there were different materials that were introduced. Some, in fact, some bonding agents went to such an extent that they were trying to bond amalgam to the natural tooth structure also.
Okay.
Later on, then it was actually Bowen who introduced the composite, I would say, to the dentistry. So Dr. R.L. Bowen, he was the main person who introduced composite to dentistry. And we should definitely not forget the landmark in restorative dentistry, that is introduction of etching.
Very true.
So this was introduced by
Buonocore.
Yeah. So he was a main person who gave the concept of etching, on which all the restorative dentistry thrives. So this is how has been the journey. Later on, as the advancement became more further, I would say that there has always been a simplification in the R&D that has happened. So the strength is definitely strength of today's composite is definitely increasing, and the simplicity is coming into picture. So earlier, I still remember that when I learned composites in my UG days and my PG days, we had so many shades and so many syringes to do one class 4 restoration or maybe a class 3. But today, the companies have also understood that by introduction and doing a lot of R&D, we can simplify the steps.
True.
And we can do the same result in less number of syringes.
As you said, that the strength of the composites is increasing, the number of filler content and everything is increasing. So isn't it a little more confusing to the dentists that are practicing out, or maybe there are certain indications to certain composites? Is it something like that?
So if you actually ask me the exact indication and that which composite can be done in which particular cavity, if we are following the right protocols, there is no contraindication in using a composite in any type of cavity. So be it my restorative dentistry or whether it is an endodontics, there is no contraindication that I can't use. Of course, there are some areas where composite may not be the first choice, but definitely it won't be a bad choice.
Okay.
Yeah.
Okay.
So let's take an example of a class 5, which is like a dreaded thing in restorative dentistry. And there are a lot of challenges that happen when restoring a class 5 cavity, because there are a lot of, stresses that come on the in that particular area. So the authors and our inventors, whatever they have introduced, earlier they always used to say that RMGSA is the number one choice, okay, in restoring those kind of cases. But if you are following a simplified layering protocol and if you know the right step, composite can definitely be the number one choice. So I don't find a absolute contraindication where composite cannot be used in day to day.
Okay, great. So, as you said, composites are one of the choices are currently going on, and they are evolving day by day.
Yeah.
You see lot of other kind of fillers that are coming
Yeah.
in. They've started putting spheroidal zirconia as well nowadays, and all these things are going on and on.
True.
But do you think that there are certain protocols that need to be followed while you are doing a composite or while you are performing a restorative dentistry, like which starts from step one, like what I would say is visualization? So I saw that you use microscope in your practice. And how has that changed for you? Like starting from the basic visualization, there are a lot of other options nowadays. Like there are loops, there are different kinds of loops. There is obviously this microscope as well.
Yeah.
How has that changed your practice, doctor?
Okay. So going on with the first part of the question, that the introduction of different fillers in the composite. So if I'm a basic practitioner and in case if I start my own practice, there will be a lot of dealers who are going to come to your clinic and they'll say that mine is a so and so company and we have this particular composite which is there. So in case if I go into in-depth classification and if I see the filler content and composition of each and every system, then I'll be super confused and I won't know what things to buy.
It happens.
So one recommendation from my side is definitely stick to the known companies, known brands which are there in the market. The newer brands which are there, they might be new, they would be promising at a later date, but at this moment it is very difficult to trust and go ahead and use their composites in day-to-day practice. So my number one recommendation is don't compromise on the quality that is there, because if you see the cost ratio, that the material cost versus what you are charging the patient, the material cost is not too high. So even if we are using the best composites in the world and standardized and the known companies, the material cost is very, very less. So what I would recommend, that please don't go into the complex classification and what kind of filler content is there. All those are too technical things. Just stick to basic things, what will help you in your day-to-day practice.
True.
Coming to the second part of your question, that magnification, so I would like to share my journey. So 2010 is when I finished my masters, and till 2017 I did not have a microscope and I didn't have a loop. Okay, during my PG days, we directly started with microscope. I never had the chance of starting with a loop and then with a microscope. So I would say that my life-changing journey has definitely started from 2017. The day I bought the microscope, there is no looking back. So till from 2010 to 2017, I would be very honest that I used to do general endo practice. There was not much of conservative dentistry and restorative dentistry happening with in my side. But moment I bought the microscope, I got to see so many things which were practically not visible without magnification. So as a beginner, I would highly recommend that even if you are an intern, I would highly recommend that you please invest minimum at least in loops. Yeah, because those loops are definitely going to show you the invisible things which are not seen in when we are treating a particular patient by doing restoratives. And it is not only applicable to endo and restorative. You can do all your day-to-day dental practice by starting with the loops.
Agreed.
And then after some years you can definitely upgrade and go with the microscope is the, like, the best thing that can happen to any person.
Yeah.
Yeah, and it can really upgrade your skills, and it can help you in a more better way.
Definitely.
Yeah.
Great. So, doctor, after that, I would head into something else that we do in restorative dentistry.
Okay.
The next step is isolation.
Yeah.
Like, it is very, very important to maintain the isolation, get the isolation, and how important is, like, invest into materials which gives you the best.
Okay. So here again, I would like to share one great story that has inspired me, motivated me, and many good things have happened because of that. So in 2015, I still remember doing one simple class 2 case. It was a normal case. The cavity was very far from the pulp. It was a basic class 2. I isolated it with a cotton roll and a buccal vestibule, one in lingual vestibule, and one in maxillary vestibule also. So everything was fine. There was no contamination happening of saliva. I did my composite restoration, and there was no high point. Occlusion was fine. Patient goes back, and after 2 to 3 months, the patient comes back with a dislodged filling, and he is in so much excruciating pain that I had to do a root canal for him. Fortunately or unfortunately, in the same year, my daughter's tooth was also decayed, and that struck me really hard. That if this kind of composite filling, if I'm going to give into my daughter's mouth, where am I heading to? So that is where I understood that there is no running away from isolation. Okay. And so in my initial days, I definitely had a rubber dam kit which was there since my PG days, but during the PG days we did simple single tooth isolations and all, but I understood that quadrant isolations is the way by which we practice day-to-day restorative dentistry. And so I've been in the shoes of many dentists where there is a fear in using the rubber dam, and what techniques are used, what clamps to use, and all this stuff. But I would say that it is like a one-time journey. Once you are on that journey and once you complete it, it is going to be like your daily bread and butter. You will do difficult isolations in maybe less than 5 minutes, and simple isolation in less than 2 minutes.
It's a
So
matter
it is
of
just
practice?
it is a matter of practice. Like during our UG days, we were learning class 1 cavity for almost 1 year, but today in our day-to-day practice, how much time will it take?
It's just blink of an
Exactly,
eye.
exactly, blink of eye. So that is what is with isolation. You need to be persistent. Even if things fail, you need to be you need to say that in the next case I'll do more better, and that is how you inculcate the isolation in
So even, like, I would say that even for us smaller fillings, please go ahead with the isolation is what the message is currently.
True.
Like, rubber dam is like magical.
Yes,
And I
yes.
think post COVID, there are a lot of practices that have inculcated rubber dam this thing.
Yes.
Yeah.
Yeah.
And so heading towards the preparation part,
Okay.
like, do you think that there are so many kinds of steps, like bird selection or everything,
Yeah.
like, you choose what kind of handpiece, because currently there are lots and lots of kind of handpieces that are coming out.
Yeah.
Do you think the awareness is there, like from a shift to from aeroter to slower handpiece, and what kind of burrs do we use?
Yeah. So regarding the handpiece, the electric handpiece definitely is a game changer. So if I'm comparing an electric handpiece to aeroter, the speeds are more or less the same, but the advantage that you get with electric handpiece is the precision, and the vibrations are practically zero. Okay, so the precision that we get while doing a cavity preparation, or let's take an example. If it is my indirect restorative case, I in the proximal box I need a very super fine and very sharp and very good margin in that proximal box. So that can easily be achieved with an electric handpiece. So I would highly recommend that a person invest in any electric handpiece which is available from the market. That will definitely be a game changer. Coming on to burrs, We have studied in Stodavan that composite has a typical scooped out preparation. So how much the amount of decay which is there, you just take a round burr or maybe a large size round burr and you just scoop out the cavity, and that is how our restoration the cavity configuration is going to be. But there have been a lot of researches that the buccal and the lingual wall that remains after that is very unsupported. So it is important that we merge the cavity with the rest of the tooth structure. So practically there is no demarcation where my cavity is ending, okay, and where the natural tooth structure is there. So for that, I would highly recommend that you use the composite finishing burrs which are available from the different companies which are there. Apart from that, the initial caries excavation that happens, it depends on the size of the cavity which is there. Like, let's take an example. I can't use a cylindrical burr to do a cavity preparation for a pit and fissure sealant. Okay, so you need to judge that how much is the amount of decay, and accordingly you should be doing your caries excavation. One added thing that really helps in the cavity configuration and the preparation part are ultrasonic instruments and hand instruments. Okay. So in these operative dentistry, when we studied during our PG days, we used to use a lot of hand instruments for minor finishing and touch up of the cavity preparation that happens. So that definitely helps. If one does not want to invest in a hand instrument, then the second best thing is ultrasonics.
Wow.
Yeah, ultrasonic tips, they are really a game changer, and you can't do a gross caries excavation and cavity refinement with ultrasonic. Of course, the main part definitely happens with the aerotor or the electric handpiece. And then for the finer finishing details, ultrasonics is really amazing.
Okay. So going ahead from there, doctor, the next step that we have is etchant, bonding agent, light cure, and whatever the composite, how to do a composite or how to go ahead after preparation. What is the next step? I know that there is a smaller step in between, which is like a recent technology, and I think we'll discuss on that, which is sandblasting. So what is your opinion about sandblasting?
Yeah. So when it comes to sandblasting, one thing that we all have to understand that each and every mouth, human mouth which is there, has enormous amount of plaque.
Yes.
Okay, it is invisible. We have plaque disclosing agents and so forth.
Yes.
Now, just before some time, I spoke that the cavity configuration is never a scooped out thing. Okay, it is like merging with the rest of the tooth structure. Practically, there is no margin. Okay, so today when we are doing any composite filling, whether it is my class 3, class 4, class 2, class 5, we are extending the composite beyond the cavity configuration on the natural tooth structure. Okay, and let's take an example that on this natural tooth structure in a particular area there is plaque. Then I am practically bonding my composite to a plaque induced surface. Okay, and this plaque is invisible. Yeah, even during our undergraduate curriculum, nobody said that for a class 2 case you can use a plaque disclosing agent, remove that plaque, and then do a class 2. Yeah. So it is very important that we remove this plaque before we actually bond our composite to any tooth structure. Okay. So now this sandblasting is definitely not a new concept. Maybe recently it has picked up in India, but it is a very I would say proven, time tested, and a necessary thing that each and every one should inculcate in a day-to-day practice. So like we need basic dental chair, we need dental x-ray, we need so many necessary things, apex locator. So sandblasting should also be a necessary equipment in your dental practice.
In your first list of the instruments that you buy.
Yes, it should be the first list, because patient is going to come, and in case if you don't have a sandblaster, and if you are telling the patient, no, let's do amalgam instead of composite, but the patient wants an aesthetic filling, and if I don't have a sandblaster, there is a high probability that my composite may debond. Okay, and let's take an example. If the composite bonds effectively, and if I have bonded my composite to a plaque induced surface, there is going to be some kind of micro leakage, secondary decay, and then eventually we are wondering that I had removed all the decay, but from where did the secondary decay actually happen? So sandblasting is a very necessary step, and each one of us should definitely inculcate into that day-to-day practice.
Definitely.
Yeah.
So as we are discussing restorative dentistry, dentistry, it is not restricted to composites. I feel the next step or the next horizon in restorative dentistry is your lithium disilicate or emax, I would
Yeah.
say,
Yeah.
and the kind of complete restorations that we are giving or post endo restorations that we are giving, that has changed big time.
Yeah.
So what is your opinion on this thing?
So let's take an example of an endodontically treated tooth. Okay, so it has been proven in literature that moment we de-roof a pulp chamber, like once we do our root canal opening in a simpler way, the stress concentrations which are there, they all get concentrated in the CEJ, that is a cemento enamel junction. The cemento enamel junction is the same area where our root canal openings are there. Okay, and let's take an example. If I have a habit, or in my practice, if I use endodontic files which have very large taper, like more than 6% taper, practically I'm thinning out the tooth structure in that CEJ area. Okay, so DK has removed some amount of tooth structure which is not in our hand, because patient has come into our office with that particular DK. Then we do a root canal opening, the strength reduces. Then I'm going to use a larger taper file, again the dentin becomes less. So practically I'm decreasing the strength of the tooth unknowingly in a far way. And on top of this, in case if I'm going giving a circumferential crown, then practically nothing is left behind. Okay, so a crown is given to strengthen the endodontically treated tooth. I feel it's a very false line. Okay, in fact, what we need is just occlusal coverage. That is what textbooks also says. All the endodontic textbooks, if you see, they all say that we need cuspal coverage. That means the cusp should be definitely protected with some kind of indirect restoration. Okay. Coming to these indirect restorations, now all the patient wants aesthetic. Okay, so even for posterior also, they may not choose a metal crown today, or maybe a metal onlay there. Then we are left with practically only two options. We have lithium disilicate and we have zirconia. But if I'm comparing those two materials, okay, lithium disilicate has some technical steps that we have to perform to bond it to the underlying tooth structure.
Okay.
But once lithium silicate is bonded to the tooth structure, it stays for life.
Yeah.
Practically, patient can eat anything, everything, and it does not break.
I think we don't tell this to the patients because they start eating any random
Exactly.
thing and anything that they come with.
Yes.
That's a very risky thing to tell to the patient. But yeah, as a dentist, we
Yes,
know
yes.
that once the lithium disilicate bonds to the tooth, it's
Yes.
for life.
It's for life.
It's for life.
And it's an amazing material. What I feel that among all the indirect materials, that's the only material that chemically bonds to the tooth. Apart from that, everything rest is just luted. So I'm luting a zirconia crown, and I'm luting a PFM crown, I'm luting a metal crown. So all of this is happening on luting. So till the stage, the luting cement stays, the restoration is going to be in place. Once it dissolves, then again it is going to debond.
Yeah.
So Emax is definitely a game changer, what I feel.
Yes, definitely. And do you think that how do patients have taken nowadays, like, so when you practice with so many things, so many steps involved, like magnification, your rubber dam and your sandblasting, what is the patient's response? Does it matter to the patient when you invest so much in your restorative practice?
True. Coming to this, Dr. Jaisal, I would like to emphasize on one important thing that is missing in dentistry, that is increasing your treatment efficiency. Okay. So treatment efficiency can be increased in your day-to-day practice by many things, by using rubber dams, sandblasting, not doing crowns, being very conservative, doing vital pulp therapy. So many things are there by which you do treatment efficiencies. So when it comes to patient's perception, patient is not going to pay you some X plus amount of money because you're using rubber dam, or maybe you have a microscope, or maybe you have a laser. So patient does not understand those things.
Okay.
All these equipments, all these techniques, all these inventions are to make our life better. So me as a dentist, I want things to be simplified so that I deliver the best possible treatment to the patient in the most conservative way.
Okay.
So as conservative I am, it definitely benefits the patient. Like I'll give you one example, so I do a lot of vital pulp therapies in my clinic. So patient comes to my clinic and he says, doctor, I'm having some food impaction happening and there is slight pain. Okay. So I ask him, question. Do you have so much excruciating pain that you're not able to sleep, or maybe you have so much pain that you're not able to chew? He says, no, there's, some mild amount of pain or negligible thing. I convince him to do an endodontic treatment.
Okay.
I start with my endodontic treatment. I open the pulp chamber, and moment I see fresh vital blood, I shift my entire treatment plan to vital pulp therapy.
Okay.
And patients are all the more happy because the endodontic case getting converted into filling, they are all the more happy.
Yeah.
But moment a filling gets converted into a root canal treatment, then they are a bit,
So prepare them for the worst.
Worse, exactly. So, so this line which is there, under promise and over deliver.
Over deliver.
So that definitely works, and increasing your treatment efficiency. So whatever needs to be done to increase your treatment efficiency, those particular steps have to be taken.
Okay. So, what do you think about the recent advancements in dentistry, which is going towards digital dentistry and the newer technologies that are coming in? What is your take on that?
Yeah, so by the introduction of these newer technology, digital dentistry, scanners, 3D printers, and all this stuff, so the number of lab steps have definitely decreased, and the transition time which is there, that has definitely drastically decreased. Because I still remember when I didn't have a scanner, I needed the impression to be picked up or maybe couriered to the lab, and it used to take 24 hours or maybe the same day it used to get picked up, and then the restoration used to come after 7 days or maybe 10 days depending on the lab which is there in India. But now this transition time is drastically reduced. One thing that has increased from the lab side is the skill that they use in the exocad. Okay, so we need to have a really highly skilled technician who is great with the exocad skills. So I would say the efforts from the lab side has increased, but from the dentist side it has become drastically less.
Okay. So as you said that the participation of the lab in the whole process of restorative dentistry is a lot. So when you communicate to the lab communication is a skill, I would rather say.
True.
And what is your take, or what is your opinion that how, instead of just filling out the prescription that they have given, that they have created, should there be any other steps involved that you do from your end so that the communication is more and more better?
Yeah. So in this, Dr. Jaisal, photography documentation plays a very vital role in this, okay? Because lab, see, most of the time when we send a case to a lab, the patient can either see, the lab guy can either see a stone model or maybe he can see an STL file from an exocad, okay? But he practically does not know what is the shade of the tooth, how are the contacts, how is the opposing tooth, so many information he is actually lacking. So when it comes to photographic documentation, investing in a camera definitely makes sense, okay? Every dentist at some point or the other, if he is investing from day one, that's the best thing to happen. But if not on day one, maybe after some few months, each and every dentist should invest in a camera. And it is not only for the lab guys also, because so many things when I document, I transfer the photos to my computer or my PC, and when I zoom and see those images, there are so many changes and so many wrong things that I've done, and I can correct those same things later on.
Okay.
So investing in a camera will make the lab's effort also very, very easy. You will give more better communication to the lab.
Yeah.
That is
okay. So as you said that photography, even you see certain corrections that, so it basically acts as a third eye, as that I would like to mention. Even while doing the patient, even maximum magnification you use, there are certain points that you miss out, maybe in the same arch or in the opposite arch. So any preferable camera that you would suggest to the listeners?
So definitely the major game changers in photography, they have been the Nikon and the Canon. These two companies are there. There might be some minute differences between the two companies, but as a dentist level, those changes are definitely not relevant to us.
True.
Okay, so I would recommend that any dentist can go with any company camera. There is no bias in this. But what is important are two things: the macro lens and the light. Okay, so let's take an example. There is a dentist who wants to do just basic photographic documentation. He's not interested in doing high-end photography and all this. So a ring flash and a macro lens, 100 macro lens, is more than sufficient that he can do, and he can practice all his life with just using a macro lens, a ring light, and a basic camera. Okay, but if there is a dentist who really wants to go in depth and he wants to do everything in photography, like I have everything in dental photography. I have twin flashes, I have soft boxes, I have diffusers and all this stuff. Then the sky is the limit, so as the light and the different diffusers, they come into picture, we can create those artistic photos for our patients. So it all depends on the patient, on the dentist's perception, how deep he wants to go. Yeah.
Okay. So next I would ask you for some advice to the dentists who are just starting in, or like probably studying dentistry or something. So where should they start from if they want to get deeper into restorative dentistry? Suggest some books or some doctors who they need to follow probably to get a start or starting point for restorative dentistry.
So Dr. Jaisal, that's a great question that you have asked. Now, I would like to say that any new dentist who comes into the practice, the basic steps that are involved in day-to-day dentistry, they have to be mastered first. Okay, so it is a basic root canal, how to do a basic filling, how to do a normal post-endodontic restoration. So all these are daily bread and butter dentistry. Okay, but unfortunately, I see the reverse trend where each and every beginner is venturing out into implants, smile designing, and all the other FMRs. So the basic dentistry which is there is definitely lacking there. Okay, so those things are definitely important in day-to-day practice, but they can come at some years later once you have mastered this. Okay, so your first step should be to do all these basics. So we have excellent mentors in India who teach about basic endodontics, advanced endodontics, restorative dentistry, whether it is direct, indirect. So I would highly recommend that you go ahead and do some research on these courses which are available, and get mastered with it.
I totally agree with you, because right now currently there are so many overwhelming things going on in dentistry. True. Because it seems like it has become more and more investing part, like you should invest in this, you should invest in that, multiple things. But I really appreciate that your suggestion is first stick to the basics. Because basics are something, if you get like clear, if you get excel in your basics, then you can look after these things. Perfect. So any 3 things or 3 points that you would suggest to our dentists out there?
So Dr. Jaisal, what I feel that when you start your own practice, honesty, ethics, they definitely play a very vital role in growing your practice. See, by being honest and being ethical, the journey is very slow. Okay, maybe you won't see the numbers in 1 year, maybe not in 2 years, not in 3 years maybe, but it takes some time for the practice to build up. Okay, we should definitely not be in a rat race where in 1 year I want my monthly income to be some X amount, an exuberant amount. That is definitely going to happen by doing bad dentistry. Okay, so honesty and ethics play a very vital role. Like I'll give you some example. I have many dentists who come to my own practice to get their dental treatment done, or maybe their family members, and so whenever they approach me for any treatment, I try to avoid any root canal and any crown as much as possible. So being as conservative and not cutting unnecessary amount of tooth structure plays a very vital role, and it will help in restoring the entire integrity of the tooth. 3 things that play a very vital role in restorative dentistry, whether it is direct, indirect, are first and foremost is rubber dam. There is no looking back. Whatever be the case, the fear is all in the mind. Okay, so investing in rubber dam plays a very vital role. The second important thing is a concept called as immediate dentin sealing. Okay, so post-operative sensitivity after composite restoration is practically eliminated, and we can focus on more better things and to upskill the composite techniques. And the third important thing is sandblasting, which we have already spoken on. So these 3 things play a very vital role in any restorative. Okay. Whether it is my direct or indirect, they are mandatory things that have to be done.
You said the immediate dentin sealing. Is it a newer concept? Because nowadays we listen to it a lot. and where is it required, and like how do we go ahead with that? Because
Okay. So this immediate dentin sealing, the concept is shortly called as IDS. So
Yeah.
IDS, this concept has been introduced by Pascal Manier.
Yeah.
So he's another godfather of restorative dentistry. He's amazing mentor and great motivator. And the technique, if you go through the original article, Pascal Manier recommends that we should be using Kerr Optibond FL to do our immediate dentin sealing. Now this particular bonding agent which is there is a filled adhesive. Unfortunately, it is not available in India. Okay, so in 2021 he published one more article that in case if you are not using Kerr Optibond FL, then whatever bonding agent is there in your country, we have to top it up with a flowable composite.
okay.
Yeah, that is
To
what.
increase the
So to increase the strength of that hybrid layer
Yeah.
and to seal the dentinal tubules,
Yeah.
we are going to top it up with a layer of flowable composite. So once I have done my selective etching, once I have done my immediate application of bonding agent,
Yeah.
I have light cured my bonding agent. I'm going to apply a layer of flowable composite only on the dentinal surface,
Okay.
and then we are going to light cure it. So in India, we are going to do immediate dentin sealing in 2 steps.
Okay.
So application of bonding agent is the first step. We
Yeah.
light cure that,
Yeah.
and whatever dentinal surface is there, only on the dentinal surface we are going to place our flowable composite, and then we are light cure it, and then the rest of the step starts.
Okay.
Okay. So
Okay.
this is what the ideas thing is.
Beautiful. So I'm sure that the listeners have learned a lot of things from today's episode.
Thank
If they want to connect with you,
Yeah.
like you take a lot of courses,
Yeah.
and I would want a little bit of introduction from your end, like
Okay.
what has teaching, like how do you teach and what is your way, and what our listeners can do to connect to you so that they can get the opportunity to learn from you.
Yeah. So Dr. Jaisal, we conduct courses on 4 aspects: endodontic, rubber dam, composites, and indirect, posterior
Okay.
indirect
Restoration.
restorations. So the USP of our workshop is that we give maximum hands-on. Okay, practically there is a theory only for 2.5 an hours, and later on, whatever time remains till the
Yeah.
evening, it is purely hands-on. So there
Okay.
is so much hands-on that like so many participants have told me that now we are tired, we are exhausted, and we can't take it more, and then we'll go home and come for day 2.
Yeah.
So this is the amount of hands-on we give in our workshops. So let me give you a brief idea of each and every one. So our rubber dam workshop, which is there, it is the only workshop in India which is for 2 days. We take basic rubber dam isolations, and on day 2 it is advanced rubber dam isolations. So there are different clinical scenarios where there is a class 4, there is a class 3, there is a crown prep, and there are multiple clinical situations which a participant has to come and he has to isolate that particular area. And apart from that, we have went one step ahead, and now we do metrizing also. Okay, additionally with that. So this happens over 2 days in Pune and Mumbai. So then the second workshop that we have is the compo finisher. Okay, so the compo finisher, now when I learned restorative dentistry, there were two techniques of placing a composite into a cavity. There was injection molding and there is layering also. Okay, I learned these 2 techniques from different mentors. Okay, but I know that both the techniques, they are necessary in our day-to-day practice. Okay, so there are few cases where my first choice would be to do injection molding. There are some cases where the first choice would be layering. So that is the reason why we give exposure to all our participants with layering and injection molding both in one workshop. And on day 1 we cover anterior, where there are 3 hands-on exercises, and on day 2 it is all about posteriors. For endodontics, we have the endo finisher course, where it is again a 2-day course, and it again covers basic and advanced endodontic exercises. So right from access opening, how to do a conservative access opening, not unnecessary enlargement, how to do rotary shaping of a canal, irrigant activation, and how to do a proper core, MTA perforation repair, MTA apexification. All these advanced techniques and the basic techniques are covered in those 2 days. Okay, one additional thing what I want to highlight is gadapocha removal, because that is again a big headache when it comes when the gadapocha is hardened, and the rotary file and hand files are just not going into that hardened gadapocha. So we give exposure of all of this into that. Coming to our fourth workshop, that is the posterior indirect. So gone are the days where we are doing crowns after endodontically treated tooth, or there are some teeth where I can't do a composite restoration. Though, if the patient is not affording, definitely composite would be my second choice. But if given a choice, the first choice would be to do a indirect restoration. So let's take an example. A patient has an MOD cavity. Okay, so the first choice is definitely not composite. First choice is to do an indirect. So how to do an indirect? What are the clinical steps involved? What materials have to be used? So all these things are covered in those 2 days. Apart from that, each and every participant, from filling the cavity, he preps the cavity, he temporizes it, and in the on the day 2, we get the restorations fabricated from the lab, and then the participant bonds those same restoration to the same prep teeth that he has done. So this is what we cover in the posterior indirect.
Beautiful.
And in case if you want to connect with me, I'm there on my Instagram, so you can definitely go ahead and drop a message. I'll be more than happy to send a message across.
Super. Super. Coming to an end to this podcast, Doctor. Your views on changing dentistry day by day, and what can, dentists, how can they change their lives, or probably whatever is helpful to them, like just few tips about dentistry in general from your end.
Yeah. So coming to 2 things, what I would say, Dr. Jaisal, staying fit is very important, because we have our professional issues, like having a back pain and neck pain, because we are continuously bending, and so those issues definitely crop up over a period of time after you have done 10 years of your practice. So not neglecting your health and continuously being in the clinic is definitely not a good thing to do. So there is some time that one should definitely invest in being healthy. Second important thing is, if you really need to grow into dentistry, please invest in magnification. Okay, because moment you see something magnified, it will change your perception, and there are so many mistakes that you will come to know that these small things are happening, and automatically it will take you towards the proper advancement and a good uplifting of your skill.
I totally agree with you, because one doctor that I used to observe, he used to always say this line where he said dentistry fails microscopically first and then it fails macroscopically.
True.
So I think investing in a microscope would be a great investment. And thank you so much, doctor, for coming in today, taking time out of your schedule, and giving us so much of knowledge, because I'm sure that after this episode, dentists are going to learn a lot of things from here. Thank you so much.
Thank you.
Please press like button if you like the video, share it with your friends, comment down your views about it or any special requests that you have, and subscribe the channel. Thank you.